Bismillahirrahmanirrahim. My affectionate students, Assalamu alaikum wa rahmatullah. Today I am going to discuss about excretion of drugs. Drugs, after being biotransformation, it will be converted. It will converted to ionized, water-soluble, and polar substance. Now it will be excreted from the body. The most important avenue of excretion is kidney, then through GIT, fecal mass, and hepatobiliary system, then through lungs, then through milk, then miscellaneous routes. By these routes, drug will be excreted from the body. But the most important route is kidney via urine. Drug in kidney, there are three processes. One is tubular secretion, then glomerular filtration, tubular secretion, and tubular reabsorption. Excretion is the product of glomerular filtration plus tubular secretion minus tubular reabsorption. Now, drug after filtered, then it enters into the filtrate in tubule and moves along with the filtrate electrolyte and water. But this movement, that is excretion or tubular reabsorption, depends on the local pH. If an acidic drug in acidic urine or basic drug in basic urine, then it will remain in unionized form or lipid soluble form. It will be reabsorbed. It will not be excreted. On the other hand, if acidic drug in alkaline urine or alkaline drug in acidic urine, means when there is change in the pH of the environment, when you filtrate and pK of the drug, then drug will become polar, will become ionized, will be water soluble, will not be lipid soluble. It will be excreted from the body. It will not be reabsorbed. This knowledge can be applied in the treatment of drug poisoning. If there is poisoning with acidic drug, make the urine alkaline, or if the poisoning is due to alkaline drug, make the urine acidic. Because of this principle, previously phenobarbital poisoning, the principle was forced alkaline diuresis. Because phenobarbital used once upon a time was used as a sleeping pill, popular sleeping pill once upon a time. And as it is an acidic drug, so if the urine become alkaline by giving sodium bicarbonate, so this alkaline pH acidic drug will become ionized, will become water soluble, and it will be excreted from the body. And if there is, at the same time, as there is no edema, so to increase GFR, furosemide was given, so that it will be excreted, so that there will be increased filtration, and ultimately inside the tubule ionized drug will be excreted. So the forced alkaline diuresis was the treatment at that time in case of phenobarbital poisoning. Now, in this way, pH of the environment modifies excretion of drugs. Then there are other factors concerning kidney, that is concentration of drug. If the drug amount is more, excretion will be more. If the amount of the drug is less, then the excretion will be less. Now, renal blood flow. If renal blood flow increase, then GFR will be increased. If renal blood flow will decrease, then GFR will be decreased. For example, in case of thyrotoxicosis, in case of acromegaly, in case of hyperdynamic circulation, renal blood flow is increased. So the urine formation, GFR is increased, urine formation and excretion will be increased. At the same time, if the renal blood flow is decreased, as in heart failure or in case of burn, in case of diarrhea, in case of dehydration, renal blood flow is decreased, so GFR is decreased and urine formation excretion will be decreased. Another factor is binding, plasma protein binding. We know in drug remains in plasma in two form, binding form and free form. So binding form is inactive form, not distributed, not metabolized, not excreted. It is the free form which will be excreted from the, which will produce action, which will be distributed, which will be metabolized, and which will be excreted. So if drug more binds with plasma protein, it will not be excreted, it will not be filtered, it will remain inside the body and will produce a longer half-life. So less binding drug will be easily filtered, and will be excreted, and high binding drug will not be filtered and will remain inside the body. Now another important factor is tubular secretion. As we know that tubular secretion is an active phenomenon. GFR is passive phenomenon, tubular secretion is an active phenomenon, and tubular reabsorption may be active, may be passive. Mostly active, also mostly passive, also active. And by virtue of tubular secretion, drug will drug will be introduced into the filtrate, and this secretion is an active phenomenon, so it is competitive in nature. In Second World War time, penicillin was discovered, and it produces tremendous help for the injured soldiers. But the penicillin's half-life was very low, 1 or 2 hours. So, and it has to be given by injection route, and injection is very painful. That's why at that time a drug was developed, that is probenecid, which is actively secreted into the filtrate, and penicillin also excreted from the body by tubular secretion. So they will compete with each other. As the probenecid is more powerful, so probenecid secretes instead of penicillin, which remains inside the body and have longer half-life and produce better healing. So in this way, secretion can modify, tubular secretion can modify. Similarly, furosemide and thiazide, they are excreted from the body mostly by tubular secretion. They can also modify penicillin excretion by inhibiting secretion of tubular secretion. There is one drug mostly excreted from the body by GFR, that is aminoglycosides. Aminoglycosides neither reabsorbed nor secreted, they will be filtered and they will be excreted from the body. But penicillin mostly excreted from the body by tubular secretion. Now another route is excretion through GIT. Here unabsorbed drug from the gastrointestinal tract will be excreted through feces. There is also hepatobiliary system by which drug may be excreted. There are many drugs excreted by this mechanism. That's, for example, doxycycline, DG toxin, macrolides, ethinyl estradiol, sulindac. These drugs are secreted. This drug is carried by the bile duct and enters into the second part of the duodenum, where in conjugated form, and the gut flora elaborates enzyme which separates the conjugated, which break down the conjugated product, and the drug becomes free. As the drug is lipid soluble, they will be again reabsorbed by the gut and enters through the portal system, goes to the body and produce effect. But later on, this drug will be further metabolized in the liver, undergoes glucuronidation, and again secreted, released into the second part of the duodenum. So in this way, it creates a enterohepatic circulation. Phenolphthalein, is a purgative, exhibits this enterohepatic circulation. Rifampicin exhibits enterohepatic circulation. And here the drugs which exhibits enterohepatic circulation, they will produce bouts of effect. Now, there is another route is the respiratory tract through lungs. Now, general anesthetics, volatile liquids and gases, they are excreted from the body by through lungs, through expiration, and paraldehyde also excreted from the body by excretion. Then milk is very important for a nursing mother. As milk, we know milk has got pH towards alkaline side, so usually acidic drug is concentrated there and will be more concentrated in milk. So during for nursing mother, this is very important. Spacing is very important. Feeding should be in such a way that a drug should not be taken 1 hour before feeding or after feeding. Better to avoid drug 1 hour before and 1 hour after feeding, nursing. Now there is tetracycline is a drug which is excreted through the through the maternal milk, and they will affect the baby, affect their bones and teeth development. So should be avoided. Sometimes mother suffering from insomnia and needs benzodiazepines, and this drug excreted through the milk, and mother will be hypnotized. At the same time, baby will be hypnotized. But we want hypnosis of the mother, but not that of baby. So for nursing mother, feeding should be adjusted. Now, the one important thing is half-life of a drug. Half-life. The half-life, it can be defined as time by which a measure will be declined to 1/2, where a measure may be the time by which a measure will come to a half is called the half-life of that measure. Then measure may be the concentration of drug in plasma, that is called plasma T-half. Maybe effect of drug in the body, that is called biological effect half-life. Or maybe the elimination or excretion of drug from the body, that is called elimination half-life. For practical purpose, we usually consider plasma T-half, that is plasma T-half. Plasma T-half, we consider plasma T-half. By knowing plasma T-half, we can have an idea about the pharmacokinetic properties and pharmacodynamic properties of a drug. A drug having long T-half means a drug remains inside the body for prolonged period, and this drug is suitable for chronic emergency. This drug should not be given frequently, so patient's compliance will be good, and the drug is not suitable for acute emergency. Whereas a drug having short half-life, this drug is quickly absorbed, quickly produce action, quickly metabolized and quickly excreted. This drug is suitable for acute emergency. Its action will not be long lasting, so drug has to be given frequently, and the patient's compliance will be poor. In this way, patient's compliance will be poor. So the binding, plasma protein binding, thereby in half-life will be altered. This should be considered while considering drug therapy, whether the case is acute or whether the case is chronic one. Now, there are two kinetics, that is first order kinetics and zero order kinetics. This should be discussed a bit detailed. Most of the drugs in our body will follow first order kinetics. It means concentration of the excretion of drug is directly proportional to the concentration of drug. Now, if the concentration is more, drug excretion will be more. If the concentration is less, drug excretion will be less. In this situation, half-life will be constant, and a half-life will be constant, and a constant fraction of the drug will be eliminated per unit time. Whereas most of the drugs follow this kinetics. Whereas there is another kinetics that is known as zero order kinetics, that is saturation kinetics. Here, if the concentration of the drug more, then half-life will be altered. Half-life will be increased, and a constant fraction of a constant amount of the drug will be extracted per unit time. In first order kinetics, constant fraction will be eliminated per unit time, but in zero order kinetics, constant amount of the drug will be eliminated per unit time. And here the half-life will be increased. So drugs following zero order kinetics, here if the dose is increased, a bit increase of dose will produce great risk for the patient. So dose has to be closely monitored in this situation. Drugs like alcohol, drugs like phenytoin, drugs like theophylline, drugs like aspirin, they will follow zero order kinetics. Mostly when the drug amount, usually by concentration of enzymes is more inside the body, because body is full of enzymes, and the drug which is given outside the body, its amount is low. So as the drug amount is low and the enzymes position concentration in the body is more, so their drug will be metabolized, and constant fraction of the drug will be eliminated per unit time. But in case of zero order kinetics, especially for alcohol, the enzyme situation is very poor, very scanty, and the drug position is more, and that's why drug will fail to metabolize the drug. Enzyme will fail to metabolize the drug, and as the drug amount is more, constant amount of drug will be eliminated per unit time till constant amount. When the concentration of drug is less and the concentration of enzyme becomes superior, then it will again follow first order kinetics. So this is about kinetics of the drug. Now one thing is very important to mention here, that is essential drugs. Essential drugs are those which satisfy the healthcare needs of the majority of the population. They should therefore be available in all. They should be available in all time, in adequate amount, and in the appropriate doses for. Essential drug this concept was introduced by WHO as a component of primary healthcare. It was declared in Almata conference that through essential provision of essential drug, we can achieve health for all. One of the component, we can achieve health for all by 2080. It was decided in Almata conference. So essential drug, it should be known to all medical students and physicians. Once again, essential drugs are those that satisfy the healthcare needs of the majority of the population. They should therefore be available at all time in adequate amount and in the appropriate doses form. All drugs are not essential. Essential drugs has got some characteristics. That is, these drugs are safe drug. This drug is safe drug. Is a safe drug. This drug should be cheap drug. This drug should be available drug. That means it is not only cheap but also available. It should be available at local pharmacy. It should be available to our close, very in our vicinity, and there must be need of the community. Majority of the people needs this drug, so community need is very important thing, and drug must be efficacious. In abbreviation SANE, we can say SANE. This is the characteristics of essential drug. S means safe drug. A means available drug. Also, it is affordable drug. Available as well as affordable. And need of the community. And E means efficacious. Must be efficacious and safe. These are the very important point for essential drug. So, and there is some definition which should be noted by the students, which is important for not only SAQ but also MCQ and Viva. That is alkaloids and glycosides. Alkaloids means alkali-like substance. They are not alkali, but they are alkali-like substance. These are organic, basic organic nitrogenous substance obtained from plant, insoluble in water but soluble in organic solvent. Insoluble, and they are alkaline in reaction. Alkali is an inorganic substance obtained from mineral source. It is water soluble. But alkaloids, they are organic substance. They are obtained from plant. They are lipid soluble. They are water insoluble, and they are alkaline in reaction. In this point, it relates with alkali. That's why it is called alkaloid. Like morphine, like codeine, like atropine, like reserpine, like pilocarpine, muscarine, nicotine. These are examples of alkaloid. And this one term, glycoside. Glycosides are organic substance. They are non-nitrogenous substance. They are obtained from plant, and they are insoluble in water, but they are soluble in organic solvent. And their reaction is either neutral or acidic in reaction. So there are some similarities between alkaloids and glycoside. There are some dissimilarities between alkaloids and glycoside. Both are organic substance. Both are obtained from plant. Both are water insoluble. Both are lipid soluble. These are similarities, and these similarities are alkaloids are basic and they are nitrogenous substance, and glycosides are non-nitrogenous substance and they are either acidic or neutral in reaction, and it is composed of sugar and non-sugar moiety, which is not the case with alkaloids. So these are the definitions we should remember. And lastly, that is a term is pharmacopoeia. Pharmakon means drug, arpion means book. Pharmacopoeia is a book written by legally authorized body constituted by law. This body, the members of this body should be pharmacologists, then biochemists, then physiologists, then clinical pharmacologists, then physicians, then organic chemists. A group of body, a specialized body will prepare a book, and that book contains the drugs commonly used for a country, and with their detailed study, and that book is called pharmacopoeia. Various countries have their own pharmacopoeias, like British BP means British Pharmacopoeia for UK, USP, United States Pharmacopoeia, and then French Pharmacopoeia, then IP, Indian Pharmacopoeia, and there is PHI, Pharmacopoeia International. It is for WHO. So in our country we have no pharmacopoeia, but we follow British Pharmacopoeia. But we have Bangladesh for National Formulary. Formulary is a primitive mini type of pharmacopoeia. We have this Bangladesh National BNF, Bangladesh National Formulary. So with this definition, you have to remember the highlights of this chapter is processes, routes of excretion of drugs, then factors modifying excretion through kidney, role of the pH especially for drug modifying excretion of drugs, and then half-life, the time, once again, the time by which a measure will come to a half is called the half-life of that measure, which may be concentration of drug in plasma, that is plasma T-half, which may be action of drug in the body, that is called biological effect half-life, and which may be the elimination of drug from the body, excretion of drug from the body, that is elimination half-life. So this point should be remembered, and alkaloids, glycosides, pharmacopoeia, and zero-order kinetics and first-order kinetics should be remembered. Most of the drugs follow first-order kinetics, and limited number of drugs follow zero-order kinetics. When the amount of enzymes is more, this is normal phenomenon, the drug will follow first-order kinetics. When the enzymes in body is scanty, but the drug is more, then it will follow zero-order kinetics. So long the enzyme concentration becomes more and drug concentration becomes less, then it will again follow first order kinetics. And among the important drug which follows zero order kinetics is alcohol. So thank you for your patient hearing. Assalamu alaikum wa rahmatullahi wa barakatuh.